Hi, so if you're watching this video, probably we just got done talking about maybe a bladder tumor in the bladder. Um, so, we both saw on the video. I hope that you did look over and see so that we all kind of are on the same page on what we're dealing with. So it looks like maybe you do have a bladder tumor in your bladder, and there is a procedure for that. And that procedure will be what you need to take care of this problem 90 to 95% of the time. There's no incision with this procedure. It is done under a general anesthetic. It's called a TURBT. So everybody is going to be talking to you about a TURBT. And what that stands for is a transurethral resection of bladder tumor. You go up through the urethra while you're asleep and remove it. And that generally is what takes care of this particular tumor. Again, it's done under anesthesia. For me, this is kind of a very routine procedure. Probably done over 500 for sure of these, maybe 700, something like that. A large number. It's more common than you would think to have this happen. And so basically, under anesthesia, I go up and I take a small loop of cautery and use that loop to kind of scrape the wall of the bladder and scrape that tumor out of there. This is what we need to do, and this is the surgery that you'll need, and that's it for this tumor, as long as it does not invade past the second layer of the bladder. That's a completely different topic. That's a 5% chance. I wouldn't worry about that right now. Really what we need to worry about is this procedure that we're going to do. So it's no incision. It is quick, generally speaking. Larger tumors can take 30 to 45 minutes, but generally this is a 15 to 20-minute case. But so for us, it's not a big surgery. It's also fairly safe in that the chance of like a major complication from this procedure is quite low. The one thing we worry about really as urologists for this procedure is perforation of the bladder, where we go all the way through the bladder wall. And then we're going to either need to leave you with a catheter for a week to let that heal. Or, if it's really bad, maybe even go in and have to make an incision and close it. That's like way less than a 1% chance, but that's something we do worry about technically when we're doing the surgery. The chance of needing a catheter for a week after the procedure, that's generally dependent on the size of tumor. And if we're looking in the office and it's a lot of tumors everywhere, I might be telling you there's a good chance you need a catheter. But generally speaking, a catheter after the procedure is less than a 5% chance. But that's what we worry about as urologists. And there is actually a lot more that the patient goes through after this procedure, because after this procedure, there's always discomfort. And it's a difficult problem, especially in men. And bladder cancer is like 3 or 4 times more likely in men. So generally, we're dealing with men. Because what happens when you scrape that tumor out, it makes the bladder angry, right? There's inflammation, and there is swelling, and there is discomfort. If you get an incision on your skin or something, we can give you pain medicine and anti-inflammatories. The problem with the bladder is that when it gets mad and it's healing, it starts to contract a lot all the time, and you're having to go to the bathroom potentially every 15 to 20 minutes. And it's uncomfortable. You have to run to the bathroom. It's not that you're just making your way to the bathroom. It's like, got to go right now or I'm going to leak my pants. And this is every 15 to 20 minutes for days, 3 to 4 days. The problem with men is that the medicine that we give you to help with that can block your bladder. You have for women, it's much easier because there's no prostate. The urethra is much shorter. But for men, when we go in with a big metal scope through the prostate to get to the bladder, we're inflaming that prostate anyway, and you're already set up to like not be able to go to the bathroom. We're also kind of stunning the bladder in certain areas where we're doing the scraping, and it's not going to contract very efficiently. So you're maybe set up also not be able to go to the bathroom. The medicine to help with this frequency relaxes the bladder wall so it doesn't contract as well. And so that's also going to contribute to maybe not being able to go to the bathroom. And if we're trying to avoid the catheter, we may need to be dealing with going to the bathroom every 15 to 20 minutes for a few days. It's you know, it's just what it is. There will also be blood in the urine, and the blood in the urine is interesting in that a lot of my patients don't really have much in the way of blood for the first 2 weeks, and then there's this bloody show. And that what it is basically is that as that tissue is healing off, it's like a scab that can form and then fall off. And any little amount of blood in the urine can cause it all to look red, but also you have some kind of healing tissue product that's going to be passing to. So 10 to 14 days after the procedure, earlier if you're on any kind of blood thinner, and more severe if you're on any kind of blood thinner, you're going to see blood in your urine almost certainly again. That should be self-limiting over a couple of days. But it can potentially be, a reason that brings you into the hospital. So as far as risk of this procedure, anytime we do a surgery, there's risk of bleeding and infection. The risk of infection is about 3 to 5%. Generally speaking, it's usually not something that's going to bring you to the hospital. It's usually something we give you antibiotics for. It's very unusual to have like a fever, febrile infection, really bad infection after the procedure, but it can happen. Obviously, there is bleeding. So, if you're not on a blood thinner, it's about a 3 to 5% chance that you end up maybe coming back to the emergency room at least with blood in your urine. If you're on a blood thinner and we need to restart it within 48 hours of surgery, then we're talking more like a 15% risk of needing to come back to the emergency room for blood in the urine and maybe a catheter to get put in. So the problem is that it's kind of not a good alternative because this is a cancer, we have to remove it. And it is better than getting an incision and having to go through that whole thing, removing portions of the bladder or something. So bleeding and infection, we talked about perforation, we talked about urinary retention, and then the other thing, and then the symptoms, okay, which are very bothersome. I completely understand, and I'm with you, like it stinks, but it's kind of a trade-off, and the catheter stinks too. So I can give a prescription of that medicine to relax the bladder, but that would be like, if it's really bad, we can try it and you are risking going into retention. And then the one thing about this issue, if this, when we look in the office, I probably told you that's a bladder cancer. And the reason is because you can see it and know it. It's like seeing a dog, that's dog. You see bladder cancer, okay, that's bladder cancer. You can recognize it visually. We will get pathology to confirm, is it high grade or low grade? Is it invasive at all? Is it invasive into the muscle? But generally speaking, visually, you can see, okay, that's a bladder cancer. For bladder cancer, and I just want to get that out there, we probably talked about this already, but the chance of it coming back is high. That's because we're not removing the bladder. We don't want to do that unless we absolutely have to. So we're not removing the bladder. We're leaving it in, and whatever caused this tumor to develop in terms of exposure, if you smoked previously, or genetics, the rest of your bladder is also affected by whatever that was. So the chance of this coming back is, 30 to 50% overall, without any kind of anything done to prevent that. For high risk, high risk bladder cancer not invading into the muscle, it's more like 50 to 70% chance. We'll talk about installations into your bladder to lower that risk. Now there's a regimen that can lower that down to 15%, but that is going to be a whole regimen that we have to do for a while. And the biggest thing to know that I really want everybody to kind of hear right up front is that you have to get scoped every so often to make sure this thing doesn't come back. If you leave the area, if something happens, if you don't like me, whatever, just schedule with someone. You're going to need a scope 3 months from now to make sure it doesn't come back. and you're going to need more scopes after that. The minimum number of years for scopes is 5 years. If it's low grade non-invasive, you should have one once a year for 5 years. So again, that's something that will set you up for. But if you're leaving the area or whatever happens, you have to know that you need a scope. What I hate to see, and what's really unfortunate, is like someone had a tumor resected 8 years ago and it wasn't that big of a deal. They never came back, and now they're in the hospital with a bladder tumor this big, and now we're talking about chemotherapy if we can remove the bladder and blah blah blah. So that is a big takeaway, just to know you're going to need scopes, just like we just did in the office, for at least 5 years to make sure this thing doesn't come back. And I know people get to the age where I don't want to go to the doctor anymore, but the problem is the way that this thing shows up, if you don't scope and you don't get ahead of it, is like horrible blood clots in the ear and running into the emergency room. The nurse is trying to get the catheter in. It's just suffering. So it's way easier just to get a scope every so often. Overall, again, this procedure is highly successful in removing that particular tumor. It's a safe procedure. There are some issues afterwards, but usually it's only for a few days. And then, as you stay on top of it, you won't have to go through it again. Almost certainly. We do have regimens now that are very effective at preventing it. So that's it. Have a wonderful day.